So yeah, so I'm one of the currently 2 cardiologists at AERC. We should be having a third one start with us next year, which we're really excited about, and we're hoping will help with some of our wait times. But today I wanted to talk about identifying and treating common arrhythmias in practice. And I want to try to keep this as relevant as possible to general practice. And it's a little bit hard to try to touch on everything without doing like a full review of arrhythmias. So there's a lot of information here. I'm going to try to focus on the important points. Hopefully it's not too rushed, but I'm also hoping the handouts are going to be kind of a nice reference and review too, and things that you can come back to. So today we're going to start out talking about why arrhythmias matter and clinical signs that we can see associated with those. How to take an EKG and just review of the normal conduction in the heart. Common causes of arrhythmias, and then how I approach an EKG. Because sometimes it can be overwhelming or you don't know where to start. So I can kind of go, we're going to go through the method that I use whenever I get an EKG, either easy or hard. And then we'll talk about using those questions that I asked myself to try to come up with a diagnosis of what the arrhythmia is. And then we'll go over the different types of arrhythmias, slow arrhythmias, fast ones from the top heart chambers, fast ones from the bottom heart chambers. And we'll talk a little bit about when do you treat, when do you not. And then we'll touch a little bit on aberrant conduction that you can see on EKGs that aren't necessarily arrhythmias. And then we will talk about different clinical scenarios, like what do you do when you see a couple of these things in practice. So as far as reference books, I get asked that sometimes. I don't know a lot of the newer books that came out, but one of my personal kind of quick go-to references is Dr. Kittleson's book, which is fully and freely available on VIN. So that's at that bottom link there. So if you have a VIN membership, I do most of my reading on screens anyway. But you can print, or if you have this book too. VIN is updated a little bit too since the original release, so there's some more current information there. Dr. Kittleson also has a website, which I have a screen grab of there. And on the left side, you can see in the column there's an EKGs button. And I think there's like 30 some EKGs on there. And I think if you're looking for more review or refreshing or kind of going through things, those are actually pretty nice because you can go through and then there's little multiple choice questions where you can quiz yourself. For a couple of the arrhythmias I didn't have examples of, I did snag a few EKGs from that website, which I credited on the slide. But I think those are good referencing things if you want to in the future. So arrhythmias, not having rhythm. There can kind of be two things that we see. One is disturbances in like the rate, the regularity, or the site of heart conduction or where it's coming from. And that can cause arrhythmias that are either too fast or too slow. We can also see conduction abnormalities. Some of those don't cause arrhythmias. So like first degree AV block, bundle branch blocks can cause conduction abnormalities, but it doesn't necessarily cause an arrhythmia. But some conduction abnormalities do. It's like second and third degree AV blocks can cause arrhythmias. So clinical signs, regardless if it's a fast or slow arrhythmia, they can be non-specific to specific and significant. So weakness, lethargy, depression, exercise intolerance, syncope or pre-syncope, so like stumbling, tripping, collapsing, falling, completely passing out. Signs can be episodic. So, the dog's normal and all of a sudden he trips, falls, passes out of it for like 20 seconds and he's back up like nothing happened. That's pretty common with intermittent arrhythmias. But then we can have arrhythmias that are ongoing and sustaining. You have a dog come in lethargic, dumpy, comatose with arrhythmias. Sometimes arrhythmias, either fast or slow, when they develop, can take an animal with significant heart disease and push them into congestive heart failure. So sometimes when animals are presenting with arrhythmias, it's not uncommon for some of them to be in heart failure, either pulmonary edema with tachypnea, dyspnea, coughing, or ascites with abdominal swelling. Long-standing fast arrhythmias can even cause heart disease. Long-standing fast arrhythmias basically cause DCM-type signs to develop. So the heart gets weak, it gets big, and sometimes when we see an animal with a sustained tachyarrhythmia, like a sustained SVT, sometimes we do an echo and we're like, oh, it looks like they have DCM. But sometimes the question is, do they have DCM and the arrhythmia is from that? Or do they have this arrhythmia and it caused DCM? And in those instances, controlling the arrhythmia actually causes some of these hearts to go back to normal. So you always have to be a little cautious about diagnosing DCM in some of these dogs. So then the question that we're going to be asking ourselves throughout this talk is, when do I treat? And to me, there's really two indications. One is hemodynamic instability. Is it causing oxygen delivery issues, and are we seeing those clinical signs of weakness, lethargy, collapsing, passing out? Or is it causing electrical instability? This animal may be asymptomatic, but if there's an arrhythmia that I worry could potentially be more likely to cause a severe arrhythmia like ventricular fibrillation, then I may still treat it if the animal is completely asymptomatic. This is a little video of a pig heart in ventricular fibrillation. It's not skipping or sped up or anything, but it looks like, and the echo image is on the right there. Essentially, the heart is vibrating because there's uncoordinated electrical signal everywhere. And when the heart vibrates, it doesn't contract, so blood flow stops. And typically within a few seconds, the animal's going to get lightheaded and pass out from that. If the rhythm gets back into normal, the animal gets up like nothing happened. But if it doesn't, they pass away pretty quickly because essentially blood flow stops. And on the left here, there is, turn on my pointer here. Left here, this is an example of coarse VFib, and this is an example of fine VFib. But essentially, they're the same thing. The heart stops beating. So if there's an arrhythmia that I worry that VFib could be the consequence of, I would, yeah.
Sorry, we're not, oh, there,
Yes.
Now we're seeing your pointer. We weren't for a moment there.
Oh, what about now, are you?
Yep, we sure are.
Okay, good. All right, so taking an EKG. So standard, yeah, feel free to interrupt again if things look weird. So standard is taking from right lateral. All of the amplitude measurements and the normals for dogs and cats are calculated from EKGs from dogs or cats in right lateral recumbency. But you don't really need that for rhythm diagnosis. So while it's ideal, and I think if you can easily take it in right lateral, that's great. But we don't always need it. We just need to keep it in mind if they're not in right lateral, that the amplitude measurements may be off. But we can still say, is the heart rate fast, is it slow, what arrhythmia is going. It's important to keep in mind in anesthesia too. If you have them on their back and it's like, well, these ECGs look negative. Well, maybe it's a conduction abnormality, or maybe it's just positional. So again, not critical, but something to keep in mind as far as amplitude measurements. But most of what we're going to be talking about is more rhythm. So right lateral, less important. So when you take an EKG, we all know there's all the different leads that we can potentially select on the monitor. But I think about it in the dog in this like anatomic position. But if we think about just the heart superimposed on this, most of the left ventricle, which is on this side here, again, kind of like an X-ray. The left ventricle has more mass than the right ventricle. So when a signal goes through the heart, there's more of it going through the left ventricle than the right, or at least that's the way I kind of think about it. So the different leads are like different cameras. And so if we're sitting at lead 2, anything moving towards us is going to cause a positive deflection on the EKG, and anything moving away from us is going to cause a negative deflection. And lead 2 is usually the biggest deflection for what's happening in the heart, both with P waves and with ventricle depolarization normally. So that's why most of our EKG machines are set to lead 2, because it's going to be the biggest and it's going to be the easiest to see most of the time. And it's kind of the standard, so that's why we look at lead 2. So just again review, normal conduction starts in the SA node, which is up here in the right atrium. That's a collection of cells that spontaneously depolarize. They have their own automaticity, and so they let out a tiny little electrical spark that, and then that starts a depolarization wave that goes across the heart, causes the atria to depolarize. There's a few tracks that get that signal down to the AV node a little bit quicker. The AV node is normally the only electrical connection between the top and the bottom heart chambers in the normal heart. So everything is separate except for traveling through that node. And that node slows down the conduction, and then eventually it lets it through. And that lets it through onto the His-Purkinje system, which is like, I think of it as like the electrical superhighway in the heart. It allows that signal to go out very quickly up to the ventricles, both over the left bundles as well as the right bundle. And that quick depolarization fast on an ECG is narrow. And so that's why our normal QRS complexes are narrow, because it's happening very quickly. And in lead 2, they're upright because most of the signal is moving towards that lead 2. So just to, as we think about how it causes the EKG, you get the little spark from the AV node, which you usually actually don't see the the SA node. You get the spark. You usually do not see the SA node depolarization on the surface EKG. It's actually a little tiny blip, but that starts the atrial depolarization. And then as the atria contract first, and well, as they depolarize, which causes the contraction, you get the P wave. And then when it gets down to the AV node, it slows down. And so you get that PR interval where nothing's happening on the EKG. And then once that signal gets through the AV node, it goes out quickly to the ventricles and you get your QRS complex. And then it repolarizes. So this is just a summary of all of that. See the signal starting in the SA node, going across the atria, getting the depolarization. So when I'm talking to a client about arrhythmias, there's kind of two things. One is, should we treat it or not? And that will be our talk, the majority of our talk. And then the other is, why are they having it? And there definitely are many heart reasons why an animal may be having an arrhythmia. But there's also many non-heart reasons too. So it can become a bit of a fishing expedition of tests. So many primary heart causes, cardiomyopathies, primary heart muscle diseases, myocarditis, heart muscle inflammation or infection, heart tumors, idiopathic fibrosis or scarring. That's one of the most common causes for AV block in dogs. Or congenital, what we call channelopathies, some abnormal ion channel that they were born with, like the inherited arrhythmias of German Shepherds. But I've also seen other puppies that have really bad ventricular arrhythmias, and we never find the reason why. We assume it's some channelopathy. In humans, there's many different channelopathies for like kids who have arrhythmias. But besides the heart, there's many non-heart causes as well. So metabolic issues with electrolyte abnormalities, toxins, drugs, and then really anything. Like I think about things in the belly, so splenic, liver, GI disease, tumors, paraneoplastic, very common with GDVs, fever, systemic inflammation, brain disease, trauma, even just pain or anxiety. I don't know if you're ever anxious or excited or had too much coffee and you feel your heart skip a beat or a little palpitation. I think that that happens in dogs too. Like an occasional VPC here or there may be normal. If you're seeing a lot, probably not normal, but maybe it's made a little bit worse. Maybe when they go home it's better, or maybe when they go home they have runs of VTAC. So it can be a whole lot of things. Some dogs I've done thousands of dollars of workups and never found anything, and it was idiopathic. So I think the main takeaway from this is it can be heart related, but it may not be. So I think it's important to do almost a full body search, or just think of the big picture when we see arrhythmias. It doesn't always mean heart disease. So how do you go about investigating? I do think an echocardiogram is ideal whenever you have arrhythmias. That's really the best test to say, is there heart muscle disease? What are chamber sizes? What's heart function? Do we see heart tumors? Do we see other abnormalities? But I think it's important to screen for other things too. And I think like a minimum laboratory database is always a good idea whenever we have arrhythmias. So CBC, biochemistry profile, urinalysis. If the liver values are sky high, that's probably going to be the cause of the arrhythmias. But I think it's important to look at the whole dog and say, okay, this could be heart, but it could not. So I think taking the whole picture into account helps direct you which way to go with tests. Cardiac troponin I is a blood test you can submit. It looks for heart muscle cell damage. So I think of it as like the ALT of the heart. Troponin is part of the heart muscle, and when those muscle cells get damaged, that leaks into the blood. And the more heart damage, the higher your troponin is going to be. If it's normal or a little elevated, heart muscle damage probably is not happening. But if it's sky high, that suggests to me that there could be a myocarditis, like heart muscle inflammation or infection, like with active heart muscle destruction. And if that were the case, I would then go more down the routes of infectious disease testing. A lot of tick-borne diseases can cause myocarditis, anywhere from a cheap 40X test to a several hundreds of dollars NC state vector-borne disease panel. Bartonella in cats, protozoal diseases, Neospora, toxo, fungal diseases. Those are all pretty rare, but I've had a few dogs that I have diagnosed myocarditis in. But troponin is maybe a good screen test before we start spending hundreds of dollars on all of those tests. Ultrasound of the belly, I think, is an important next test, especially if lab work points you in that direction, or if the animal has signs associated with some other non-cardiac disease. So ultrasound, I think, is a common workup, especially if we've ruled out heart disease as a cause. If you don't have an echo, I think chest x-rays are helpful to evaluate the cardiac silhouette, look for metastatic disease for like paraneoplastic causes, and then neurologic exam, if there's neuroscience and MRI. So you can spend a lot and go down a lot. I think some of the questions are, what are you going to do with that information too? If you have a 16-year-old golden that you find a splenic mass on, maybe the client does not want to go to surgery for a splenectomy. Maybe they do. Maybe it's a younger dog. So I think that all kind of plays into my conversation with the clients of more or less how much do you want to spend and what are we going to do with this info. And also knowing that we may not find anything, which again, ruling things out is still good information. It's not like we wasted the money, but there's a chance you could spend a lot and we still don't have an answer. So when I approach an EKG, it's important to be methodical and take it one step at a time. One, that prevents you from missing things, and two, it can kind of help you come into a really overwhelming, confusing EKG. I still go through these questions in my head that we're about to talk about next. When I approach an EKG, I think with anything in veterinary medicine, as we go from vet student to vet, we go from thinking through the pathophysiology when we get diagnostic results back and trying to come up with an answer, to eventually getting to pattern recognition. The more we see stuff, we recognize it, and we don't necessarily have to do that whole mental exercise of the pathophysiology. But even like when you start to get to pattern recognition, you're like, oh, that's AFib, like from across the room. I still go through these just to make sure I'm not missing it in my head. So what are these questions? So this is how I approach an EKG. Heart rate is, I think, the most important thing and often the most overlooked thing. Because really the question is this hemodynamically significant or electrically significant? And to answer hemodynamics is, what's the heart rate? If you have an arrhythmia but the overall heart rate is normal, it's probably not causing clinical signs. but if the heart rate's really fast or really slow, it might be. And it's a good place to start, because depending what's happening on the EKG, the rate that it's happening at may dictate whether to treat or not. So it's easy to do, and it's important, and we often don't do it right away. So that's where I always start. The next is there a sinus mechanism going on? So is there an underlying sinus rhythm? And so in lead 2, that's normally upright P waves. And I say, are they present, and are they happening at a rate that the sinus node can do? You know, range of a sinus node can normally, when a dog's sleeping, could be as low as 30. When they're running around excited, I usually think sinus rates usually go up to like 240 to 250 in the dog. I've had a few dogs that go over 300, and sometimes that causes issues. But normally kind of that like 240, 250 is kind of where I think of upper normal for sinus tach. So are there P waves going at a rate in that range? Are they upright? And then are those P waves causing the rhythm? So do you have a P wave with a QRS following every one? Do you have QRS complexes that are not tied to P waves? And then what do those ventricular complexes look like? Are they narrow, normal looking, using that normal conduction system, the His-Purkinje system with the bundles? Or are they wide and bizarre, which says there's slow conduction going cell to cell? And then is it a regular rhythm, or is it an irregular rhythm? And I think it starts to get confusing when you start doing regularly or regular. Yeah, I don't know. It gets confusing. I think people think they mean different things. So the way I think about it, is it regular or is it not? And if it's not, does there seem to be a pattern? And I know that's like what it's trying to get to, but I feel like it always gets confusing. And then sometimes if it's a really overwhelming EKG with a lot going on, sometimes I just say, okay, is there a nice home base? Do I see a nice normal sinus complex, a PQRST that looks normal? So sometimes I'll search and say, okay, look, there's a normal sinus complex. Now I can extrapolate out, look for others of those, look for other components. So sometimes I'm just like, is there anything here that I do recognize? So heart rate, there are, well, first of all, I'd say always be suspicious of the number your machine is spitting out at you. Sometimes it's good, sometimes it's not. It's not uncommon where there's an animal in the hospital that's lethargic and like, oh yeah, he's a little tachycardic at 150, but then you print out a strip and you do your own heart rate and you realize it's half counted and his heart rate's actually 300. And that's something that we do need to address, where a heart rate of 150 I maybe wouldn't address. There's two main ways to do it. The average heart rate I think is typically the one I do the most and is the most helpful. Just to review, I'm sure most people remember the Bic pen method, where at 25 millimeters per second, which I think most EKGs are default to 25, 50 stretches it out a bit more to help with timing measurements a little more. Some people may have their set to 50. It doesn't really matter. I think it's maybe helpful to have it primarily as 1, unless you're doing specific measurements just for your own pattern recognition. 50 is fine, you just go through paper twice as fast. But at 25, a Bic pen with the cap on is right about 6 seconds long. So you put that pen down, you count the number of complexes that it covers, multiply by 10 to get complexes per minute. And you may see abbreviations CPM in my talk. That means complexes per minute. It's essentially the same as beats per minute. The caveat is not every complex always makes a heartbeat. So it's technically more correct, but you can use them interchangeably, really, when we're talking about EKGs. And then at 50 millimeters per second, you put the pen down, it covers 3 seconds because everything's stretched out more. So you have to multiply that by 20. So I think I encourage you to do that often, especially if an animal's not doing well, if it doesn't seem right what the numbers telling you on your machine. Instantaneous rates, I think, are helpful in a couple scenarios. One is if it's a very regular rhythm, you could probably just do an instantaneous and it'll give you the approximate average heart rate. If you have specific areas, you want to say what's happening in these few beats, they'll tell you the heart rate there. Or where I often use it is if I have 2 early beats in a row, like 2 VPCs in a row, I'll get the instantaneous rate of just those 2 beats. And that will help me determine should I treat or not. Because if it's normal to slow, I'm probably not going to treat. But if you're having a couplet that's really fast, I may start thinking about wanting to treat that. At 25 millimeters per second, you count the number of little boxes between complexes, and I usually go from start to start of the complex. If they're the same, you can go like R to R or T to T or whatever. But especially if the complexes are multiform, I usually go from start to start. Count the number of little boxes. At 25, you take 1,500 divided by the boxes, and at 50, you take 3,000 divided by the little boxes. So why does heart rate matter? Well, heart rate is one component of cardiac output. Stroke volume is the other. And the reason why your heart rate normally increases when you exercise, or at least people who exercise tell me their heart rates go up, as you need more oxygen delivery to your body, the heart rate goes up, which increases cardiac output, which increases oxygen delivery to the tissues, to the brain. When you're bradycardic and your heart rate is really low, your cardiac output is going to be down. The problem happens, though, when you start to get above physiologic high heart rates. If you start to get into the tachyarrhythmias, there may become a point where your heart rate is going so fast that the ventricle doesn't have time to relax. So instead of relaxing and doing a full stroke volume every time, it's going so it's going so fast that it doesn't have time to relax, so your stroke volume goes down. And then there's a turning point where your cardiac output starts to go down again. So that's why dogs with heart rates of 350, 400 are often not able to get up, just because they're not getting oxygen delivered to their tissues. So we really want to focus on keeping that heart rate in the normal range. Let's see, just gonna check to see. Awesome. So we're gonna start to get into looking at some examples of these different arrhythmias right now. And again, if you have questions that come up, feel free to put them in, and I'll check them either later in the talk or at the end of the talk. So bradyarrhythmia is looking at this left because the heart rate is so low. So let's just kind of practice going through our questions with this one. So first things first, what's the heart rate? This is at 50 millimeters per second. Again, maybe a little more stretched out than what you're used to seeing if your machine's set to 25. But we put our Bic pen down, and it covers 5 complexes. So 5 times 20 is 100. So it gives us, and most of these are going to be dogs. I'll tell you if it's not a dog tracing. But so 100 beats per minute for a dog, normal. So I'd say this dog has a normal heart rate. Next question, are there P waves? Yes, I do see upright P waves here. And similarly, covering those P waves with the pen, I get the same rate of 100. So that's a very acceptable rate for a sinus rate. Uprightly too, there probably is an underlying sinus rhythm. Every single one of those P waves has a QRS that follows it. And every QRS I see has a P wave in front of it. Sometimes the question though is, are they correlated or not? So one thing I sometimes do is you take calipers and you put it from the beginning of the P wave to the beginning of the QRS, and then I move that around on all the complexes and say, is there a consistent PR interval? There's some diseases where that does not hold true, but for most of the time, you're gonna have a fixed PR interval. If I'm trying to say, are these P waves causing this or not? And yes, if you look, there's the exact same distance between every P wave and QRS complex. So I can say there's an underlying sinus rhythm. The complexes are narrow, normal looking. So it looks like conduction through the ventricles is normal and probably coming from the top in order to get onto that conduction superhighway. And it's irregular. If you look at the distance from this complex to this complex, and then you compare the distance from this complex to this complex, they're different. One's longer, one's shorter. Now, if we had a longer tracing, we may see bunches of a bunch of faster, a bunch of slower, a bunch of faster, a bunch of slower. This is very typical of a respiratory sinus arrhythmia, a very normal finding in a relaxed dog. And then we ask the question, is this hemodynamically or electrically unstable? And the answer is no. So, I think most of us would probably agree we don't treat sinus arrhythmias in dogs, especially if they're asymptomatic and doing well. Let's do the same thing. Again, at 50, we put our pen down, we count 3 complexes, so that's 60, which is relatively on the low end. For a relaxed, sedated dog, sleeping dog, that might be normal. For an anxious dog in the hospital, maybe that's not quite normal. Maybe that's too low, and is this as high as this heart rate can go? Maybe that is a problem. Similarly, yes, we see P waves in there. We see a QRS for everyone. We don't see any QRSs without a P wave, and QRSs look narrow and normal. So yes, P waves, it's sinus. It's conducted normally, so we have a sinus rhythm. It's irregular, so it's a sinus arrhythmia, but it's relatively bradycardic. So the question then is, well, why is it slow? And in general, there's 2 main causes. One is high vagal tone, and then the other would be primary conduction disease. So in this case, would it have a sinus node disease that's causing the sinus node to go too slowly? So the way that we can try to sort that out is to do an atropine response test. So atropine is a vagolytic, so it takes away the vagal component. And it says, okay, no more vagal tone, what's the heart rate going to do? And so the indications to do one is if you have a heart rate that's too slow or pauses that seem too long for the situation, either from the sinus being too slow or signals getting blocked at the AV node. Is it too slow, or is the block from vagal tone? If you have an asymptomatic animal, maybe it's less important. Maybe you don't need to do one because you're probably not going to treat it anyway because they're able to run, play, do their own things, not having signs. But if you're going to be doing anesthesia, it starts to become a little more concerning because the question is, well, if their heart rates get too low during anesthesia, can I get the heart rate up, and are they going to respond to drugs? The cautions I always say with atropine response test, if they're also having fast arrhythmias, so if there's a lot of early ventricular beats or runs of VTAC or SVT, the atropine could make it worse. Or if they're like having Cushing's reflex, and if they're severely hypertensive, that bradycardia may be protective, and giving atropine could cause the brain blows up, but vessels can rupture and cause problems. So I always like to check a blood pressure before doing an atropine response test. So where does vagal tone normally come from? Again, can be normal in a relaxed dog. Cats really should not have sinus arrhythmias. So if you have a cat with a respiratory sinus arrhythmia, that's going to make me a little more concerned about high vagal tone. But then my general categories for what's a cause of high vagal tone is eye, brain, lung, or GI or belly. So like glaucoma, intracranial brain disease, primary lung disease, and a lot of dogs with chronic cough not associated with heart failure. A lot of times they'll have slower heart rates or pronounced sinus arrhythmias. Or dogs who are having diarrhea, vomiting, GI issues. So I start to go searches in those directions for causes of high vagal tone. So I typically give 0.04 mg per kg. I usually give it IV because it usually works faster. But you can give it IM or sub-Q. No matter how you give it, I always give them up to 20 minutes to respond. When you're giving it IV, it could be as quickly as just a few minutes. Sorry, I thought I heard someone behind me. A lot of times it's within 2 minutes, but even IV, I still say, okay, you have up to 20 minutes to respond. And a normal response is greater than 150 beats per minute, sustained, regular, with no AV block. So if that happens, I consider that a normal response. And if it responds normally, that means it's likely vagally mediated. But if it doesn't meet all those criteria, then I'd say there probably is at least some component of conduction disease placement. and I would not anesthetize that animal without a temporary pacemaker placed first. That's something that we can do at AERC. Essentially, it's putting a lead. We often go through a leg vein, sometimes a neck in really small animals. We'll use fluoro to put a lead into the right ventricle, attach it to an external pacemaker, and then if their heart rates drop too slow, we can set the heart rate to whatever we want with the external pacemaker. So this is this dog's atropine response test, and within 2 minutes, this is the EKG I got. If we do a heart rate, I think it's right around 250, it looks like. It looks like there's 6 little boxes between 2 complexes. So 1500 divided by 6 is 250. It's regular, it's sustained, it's a sinus tach, there's no AV block. So this is a normal response. So this tells me that dog with a heart rate of 60, it was all vagally mediated. You know, sometimes when you get pronounced sinus arrhythmias, sometimes the question is, well, how long of a pause is too long? So if we do a heart rate on this, depending where we put our Bic pen, we may get 0, because I think our Bic pen would fit in there. But if you look at the ends and you do the instantaneous rates, it's anywhere from 90 to 60. So this dog has a 6.5 second pause, which probably is going to be too long. But going through our questions, are there P waves? Yes, I do see P waves present. There's one here. Is there QRS for every P? I don't know. I guess I don't see any P waves without QRS complexes, but I am seeing some QRS complexes that may not have a P wave, like this one right here. This one has one, but it's negative. This one, similarly, maybe negative, maybe that's a little negative one. So it seems like there are upright P waves, but some of them are a little questionable. The complexes are narrow and upright, so it does look like this is the ventricular conduction is still supraventricular in origin, but it's not regular. You know, this would be one that I would do an atropine response test on as well, but really a 6.5 second pause is too long. So I don't know, like look at a dog and count to 6 or 7, and that's a long time for the heart not to beat. If you're looking at the EKG, at this point right here, you're probably getting a little nervous, like, is the heart ever going to beat again? This here, without a P wave, this is what we call a junctional escape complex. So it still uses the normal conduction, but it's a safety mechanism where a spot by the AV junction kicked in and said, okay, ventricles we haven't beat in a while, it kicks in, but it's close enough to that AV node where it can still jump on that fast conduction. So that's why it's still narrow nodal looking. But yeah, this is what we would call sinus arrest, where the sinus node, there's no P waves, it just stops for 6 seconds. And so this dog probably has 6 sinus syndrome. I would not anesthetize this dog. So how do we treat them? So in hospital, atropine or glyco, you know, your typical anticholinergics. Atropine usually acts a little faster, glyco usually lasts a little longer. I've had some respond better to one than the other, so sometimes if I'm not getting a response. Other things to keep in mind, are they hypokalemic or hypothermic? Hyperkalemic or hypothermic. Sometimes if they're cold, they're not going to respond to the atropine as well either. So warming them up, so checking things like that. Long term, so if an animal has a bradyarrhythmia, the question is it causing clinical signs, and is pacemaker an option for the owners and the dog? Sometimes drugs to help drive the heart rate, like theophylline. Theophyline's in the xanthine family, which is like caffeine and chocolate. So while it's a bronchodilator, it can also drive heart rate. Hyoscyamines and anticholinergics, so kind of like an oral version of atropine. I usually don't see dogs with SA or AV nodal disease become tachycardic on these, but I have found clinically it may prevent those episodes where they have pauses for 10, 20, 30 seconds that are causing syncope. But a lot of times if they have bradyarrhythmias that are not responding to drugs, pacemaker is really what you need to treat that. All right, let's do this one. Again, first thing is always heart rate, normal at 100. There are P waves, but we see a P wave here that doesn't have a QRS complex. All the complexes are narrow and normal, and the rhythm's irregular. So putting that together, we have sinus rhythm. That's a little bit irregular, so sinus arrhythmia with one P wave without a QRS. That's second degree AV block. Again, second degree means some of them get through and some don't. Is this hemodynamically or electrically significant? Probably not. An occasional drop beat, the dog is probably fine, not having signs. But what happens if they start doing it more? And so, same thing, except this time our heart rate's 50. Remember, it's always good to start with the heart rate. We still have P waves. Some are conducted. If we measure that PR interval, they're pretty close, pretty similar. Empty mechanism, not anything coming in early, it's coming in late. But we're having a lot more P waves that are not getting through. So still second degree AV block because some are getting through, but it's a higher grade second degree AV block. And this dog may be lethargic. And then, the question is, let's say this dog comes in with lethargy and diarrhea. The question is this a bradyarrhythmia that's hypoperfusing the gut and they have diarrhea because of that? Or do they have primary GI disease causing the diarrhea, which is causing high vagal tone, which is then causing the AV block? So again, to try to sort out what vagal component there may be, I would do an atropine response test. And same thing, I gave 0.04 mg per kg IV. And this is by 20 minutes, this is what we got. If you actually do the P wave rate, so you put your pen down, it's actually over 150, although over here nodal disease too. But we still don't have one-to-one conduction. And a normal atropine response test is regular one-to-one conduction tachycardic. So this would be an abnormal response. So this dog likely does have primary AV nodal disease. AV block, vagal tone, like we've talked about, it's been documented in young puppies to commonly see mild second degree AV block. Drugs, toxins, a whole list of drugs there. Hyperkalemia, myocarditis. I had a dog with high grade second to third degree AV block. Got a pacemaker. We did troponin, it was sky high. Did tick testing, found that he had rocket mounted spotted fever. Did a course of doxycycline for a month. And when we rechecked him, he was completely sinus again with normal conduction. That's rare. Normally it's that idiopathic fibrosis, but it's possible. But idiopathic fibrosis here is the most common cause of primary AV nodal degeneration in dogs. Endocarditis or neoplasia, the aortic valve is right by that AV node, and if you have a vegetative bacterial lesion that can eat into the AV node, or you can get tumors there, not as common either. Those are different causes. Just to kind of finish out the AV blocks, heart rate's 20 to 30, but we see the P waves, and if we do a P wave rate, we get 160. So that sinus node is trying to beat fast. The question is, are these complexes from the SA node or not? Is this second or third degree? Here you can be like, oh, I guess maybe this P wave could be causing this complex, but if you start measuring, they're all different PR intervals, and these complexes are wide and narrow and bizarre, so they're a ventricular escape. If you third degree AV block, I think give a dose of atropine on the rare chance that it's going to improve it, but a lot of times it won't, and really this needs referral for an emergency pacemaker if the clients are interested, because if this escape rhythm goes away, the dog could die. So we'll start going through a little bit faster. So we won't necessarily talk about each step, but just think about that's what we're going to be doing as we're going through. So heart rate 50, so slow. I don't consistently see P waves. I'm always a little cautious when I don't see them because I know they could be buried somewhere. They could be really low amplitude that maybe they'd show up better on a different lead. But I don't see any here. And the complexes are a little bit wide and bizarre. So maybe are they coming from the ventricles, or are they just conducting aberrantly through the ventricles? But it's a very regular rhythm. But this is essentially atrial standstill. And the two main causes, hyperkalemia, I think is one common cause. So block cat, you see this, no P waves, slow, wide, bizarre, regular. They're probably hyperkalemic. Addisonian crisis, I've seen it in a dog too, with an EKG like that. There can be a primary atrial myopathy, like in young Springer Spaniels. These pictures here show someone holding like X-ray film or negative film inside an atria, and you can see how paper thin that is, just because the muscle goes away. But the myopathy usually, it's not just atrial, it often does eventually start to get down into the ventricles too. And here they have on the ventricle there. This is just a nice example of a cat who was blocked with a potassium of 11 when it came in. And over time as they treat, you can see how the complexes get more narrow, the T waves start to get more tented, and then eventually they get more narrow, and finally T waves again as it reappears. So a lot of times when you see wide bizarre complexes, we often say VPCs, but the P means premature. And so I don't want to be like pedantic with like naming, but to me, I think this one's important because you manage premature and late beats very differently because they mean very different things. So is it coming in before or after you'd expect a normal beat to come in? So if you look here, there's a pause, and then you have a wide bizarre beat. Same, this dog I would say has two ventricular escape complexes, but it has one VPC or one premature complex here. So it's important to start thinking about the timing of, are these early or late, and what do I think is going on? Let's see. So moving into tachyarrhythmias, let me just see if there's, I can just take a look quick. There's questions here. Oh, these look like really good questions. They're kind of long though. So why don't I go through things at the end? Yeah, perfect. I'll just keep going through here. So tachyarrhythmias. So those were the slow ones. Now let's kind of talk about the fast ones. And the fast ones will break up into top and bottom heart chamber arrhythmias. The top heart chamber arrhythmias we'll start with. Going through our questions, normal heart rate, but we see one early beat. And it looks like there's a negative P wave in front of it. And a lot of times when we see P waves that are different than the normal upright ones, they're probably coming from a different part of the heart. So we usually use the word P prime to imply it's not sinus. So we see, we go beat, 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 beat. So we have an early one here with a negative P prime, but the complex looks exactly like the sinus complexes. So this tells me it's still coming from the top. The sinus node sits in the right atrium, and lead 2 sits on the left leg. So when your sinus node fires and your atria get depolarized, the signal's going towards lead 2, so that's why you get positive P waves. So if you have a negative P wave, it's probably starting on the left and then moving away. So when I see APCs with negative P prime waves in front of them, I'm going to be thinking left atrial in origin. And if this is a small dog with a really loud murmur, I'm going to be saying, well, maybe this dog has left atrial enlargement. You know, it's not definitive, but these are the things that I'll start thinking about when I see things like this. A single early heartbeat here and there, probably not causing the dog problems, probably doesn't need to be treated. But what happens when you start to have 2 in a row? So here we have this slow sinus arrhythmia that's irregular with P waves, but then we have 2 coming in a row. Or what about down here where we have 3 or 4 in a row that are quickly? So we have little runs of SVT. So the question is, when do you treat and why? So again, APCs, they look like normal sinus. You may or may not see a P prime wave in front of them. Sometimes you may, but sometimes you may not. To me, it's just like a normal beat that looks like it comes in really early. Sometimes it can be hard to differentiate from a sinus arrhythmia when you get a lot of variation and faster, slower. And sometimes I don't know. But sometimes if it's like a regular rhythm, you get one that comes in really fast, that's probably an APC. So causes, again, going back to that laundry list, heart or not heart related, but I often think about, is there atrial enlargement, is there a tumor? There's some cavaliers that have minimal heart disease, no heart enlargement, that have APCs. Anecdotally, it just seems like some cavaliers just have APCs. But you can find it in other dogs, and then the whole long list of non-cardiogenic causes. So do you treat them? Singles, probably not. Couplets, triplets, maybe. You got to start looking at the bigger picture of what's going on. But if you have run of multiple in a row and you have SVT, yes, I would treat that. In general, I'm less concerned about electrical instability with APCs. So sudden death, much less common compared to ventricular arrhythmias, but possible. It's usually more of the hemodynamic stability, the heart rate going so fast, decreased cardiac output, potential tachycardia-induced cardiomyopathy. Those are the things I'm more worried about. So here's a dog that comes in. We do an EKG. You do your heart rate, you get 280. Like, boy, that's kind of fast. You know, sinus tachs, usually I'm thinking 240, 250 max, but they can go over 300. Are there P waves? Boy, maybe. You know, if we start looking in here, yeah, there's kind of some consistent bumps over here that have a pretty consistent PR. Like, but then sometimes it's like, well, is that part of the T wave? Because sometimes T waves can have bumps and you think it's the P wave. So sometimes you don't know when it's going so fast, if there's P waves or not. But the complexes are narrow and it's regular. And almost all fast arrhythmias are going to be regular, with a few exceptions, and those exceptions we'll talk about in a little bit, and that's important. So, but fast, narrow, regular, my two rule outs are going to be sinus tach or SVT, or supraventricular tachycardia. So how do you differentiate? Well, you can start with a vagal maneuver, which can be helpful both diagnostically and therapeutically. You want to make sure you're recording the EKG when you do it, because what happens while you're doing it helps answer the question for you. Sinus rhythms usually have a gradual onset and offset, where SVTs usually have a sudden onset or offset. So if you can get that captured, that's really helpful. And there's kind of two main ways we do it in dogs. I have the best success, with ocular pressure. So I close the eyes, I put my thumbs over, and I do slow, steady pressure. And you know, the eyes are, they have the retractor bulbi behind them. And so the eyes can actually sit back a ways in the head. And like when you see a really dehydrated animal, their eyes are really sunken. So a lot of times you have to push a little further than you would expect. And it's not that I'm pushing hard into the eyes, it's just that the eyes retract as you're putting your thumbs in. And sometimes for big dogs, I may go a phalanx deep, like to the knuckle in the eye socket, which feels really weird. Again, it's not that you're jabbing hard, it's just as the eyes retract, I just put slow, steady pressure. And then hold for, usually don't need more than 5 to 10 seconds. And then see what happens on the EKG. Sometimes nothing happens and then you don't know, but sometimes things do and it's helpful. Carotid body massage, you actually have to get way back behind the angle of the jaw, almost at the base of the ear to rub there. Sometimes when you're doing it, you actually choke the animal a little bit, which actually may vagal them too. I don't know if you ever noticed, for a panting dog, you get a heart rate of 160, and then when someone holds their mouth closed and they just start breathing through their nose, their heart rates drop. That's a little mini vagal response there too. So sometimes just holding panting can even break arrhythmias. IV diltiazem. So the idea with the vagal tone is that you're slowing conduction through the AV node, and that can either slow the rate or break a rhythm that's using the AV node. So that can be helpful in diagnosing what the arrhythmia is. IV diltiazem is a calcium channel blocker, and the AV node and sinus node are very calcium channel dependent. So that will slow those down too pharmacologically, besides just doing a vagal maneuver. Lidocaine doesn't act at the AV node, can be helpful in other instances. It's not wrong to give any tachyarrhythmia dose of lidocaine or two. If a narrow complex arrhythmia breaks with lidocaine, that means it could be a pathway, but that's not common. So usually we're doing more IV diltiazem for that. In humans, you may read about adenosine. Dogs don't have adenosine receptors on their AV nodes like people do, so it doesn't really work. But so do a vagal maneuver on this dog. If you look over these course of these 3 progressive rhythm strips, it gets gradually slower and slower. If you compare the R to R at the bottom here to the top, you can see how much bigger it is. Now this is actually a lie. This is actually from a halter of a dog that was running that then relaxed and it slowly came down. But your vagal response would look similar. You get a gradual slowing of the rhythm. So that dog has a sinus tach. And sinus tachycardias are usually not due to heart disease. The exception is if a dog's in congestive heart failure. A lot of times that's sympathetically driven, which they're going to have a sinus tach from that. But it's not the rhythm that we need to address. We need to address the failure. If they're not in heart failure, you take x-rays, their heart's small. It's probably non-cardiogenic. So hypovolemia, shock, fever, pain. So giving fluid bolus, giving pain meds, toxins, pheochromocytomas. So it's basically doing an investigation as to why and correct the underlying problem. And rarely do you actually need to treat sinus tach. Here's another EKG. Heart rate's only 240 this time. It's in the range of sinus tach. Complexes, pretty narrow, maybe a little wide, but not crazy wide. It's regular. So again, I did a vagal maneuver on this dog. And you can see top rhythm is where we started. Here, maybe this one slowed down a little bit, but then all of a sudden, you have a bigger gap and then no complexes. And we have a few P waves here that aren't conducting. So my vagal maneuver hit that AV node really well. So it completely blocked it for a few beats. Then we have one that came in, and then we have a few more blocked P waves, and then normal, and then an early, and then it stopped, and then a normal, and then right back in again. So this is a dog who has SVT. It can be a little confusing when you start to have these transitions because sometimes it's just off and on. This one had a few stuff going on, but this is a dog who had SVT. That dog actually went back into SVT shortly after that vagal maneuver. So here it is in SVT again. I did another vagal maneuver and then it broke for good. And then the dog was sinus. And the dog was actually sinus for the rest of the appointment. It came in SVT. So treatments, vagal maneuver, again, in this case, it was therapeutic. It broke the arrhythmia. A lot of times they may go right back in. Injectable drugs in hospital, diltiazem. This is the dose here. The big thing about diltiazem is you want to give it slowly and stop as soon as the rhythm breaks or the heart rate slows to a normal range. So I usually dilute out 0.15 mg per kg to 1 mil, and I have the technician give 0.1 mils per minute. And again, once the rhythm breaks or once the heart rate hits 160 or lower, I stop giving it because you don't want to overshoot it. If it doesn't break, you can repeat that one more time if needed. Procainamide can treat both super and ventricular arrhythmias. I feel like most general practice probably don't have that on the shelf. It has become a little bit more expensive too. IV digoxin, I've never used, honestly. I know Dr. Michelle Rose has used it a few times, and I think somewhat recently too. So it's in those refractory supraventricular tachyarrhythmias. I think it could be beneficial, but probably not something you're really going to keep on the shelf. Beta blockers can help, but most of the time, beta blockers can have significant weakening on the heart in an animal that may have heart disease that could push them into or worsen heart failure. So I'm almost always avoiding beta blockers. Chronic go-home treatments, diltiazem XR is usually my first choice. There's standard release and extended release. I prefer the extended release. It's every 12 hours. But standard release is okay too. Digoxin, I usually add that in as a second line if I'm not getting good control. I've been starting to use sotalol a little bit more instead of just blocking the arrhythmias at the AV node like diltiazem and digoxin do. Sotalol may help treat the focus of where those arrhythmias are coming. We'll talk about it with ventricular arrhythmias a little bit, but sotalol, primarily potassium channel blocker, but does have some beta blocking properties. And again, I worry about causing the heart to weaken and either cause or worsen heart failure if you start it without knowing what's going on with the heart. So diltiazem is usually my start. The extended release comes as 240 milligram capsules, and there's two versions. One, you pull the capsule apart, one has granules inside, but there's actually another version that has tablets inside, usually 60 milligram tablets, and a lot of pharmacists don't even know this. I put some brands I know that usually do have them, but you dose off the tablets then. And this is the dosing range for the extended release here compared to the standard release. With the extended, I usually start at the low end of the range. The standard release, I find I usually need to start more towards the high end, just because I feel like it's not as effective, but it can be helpful. Digoxin, it's kind of like a vagal mimetic, so it almost works like vagal tone at the AV node by slowing some of the conduction. Has some advantages that it actually increases contractility, unlike some of the other antiarrhythmics, but it can cause toxicity. And so you always have to be, there's things that can worsen that toxicity too, like kidney disease, hypokalemia, dosing off of fat or ascites, but it works well in combination with diltiazem, so I often use it in combination if I'm going to use it. It involves, there's a bunch of numbers here and calculations. You want to dose off lean body weight, and then usually I like to check digoxin blood levels after starting to say, are we in a therapeutic or potentially toxic range? And I usually like to check trough levels, so anywhere like 8 to 12 hours after the last dose. Signs, GI upset, anorexia, vomiting, diarrhea. If those develop in a dog on digoxin, I usually skip a dose and restart lower, because really high doses can actually cause arrhythmias and worsen arrhythmias, both supraventricular and ventricular. We talked a little bit about sotalol. I know we got a little bit of a late start, but I also don't want to make us go too late either. And I hate to rush through stuff. I was a little over complete, so I'm hoping your handouts will be helpful. And I'm always happy to talk to people too if you want to email or follow up with things. I think I'm just going to try to touch on some of these arrhythmias and go over their key points and diagnosis points. So this is tachycardic, narrow, and irregular. So even before we look for P waves, that's going to be AFib till proven otherwise. So narrow tachycardic and irregular, AFib till proven otherwise. Treatment for AFib is going to be the same. So diltiazem, XR, and digoxin are usually the drugs I use. When a dog goes into AFib, usually it's due, you have to have a lot of atrial mass. So a lot of times these animals are going to have severe heart disease. When you lose that atrial kick and the atria just start vibrating, like we saw the ventricle in that original video, when the atria start doing that and you lose that atrial contraction, you lose anywhere from 20 to 50% of your cardiac output. With exercise, the atrial kick is very important. So if you have a dog with severe heart disease and you take away some of that cardiac output, a lot of times they're going into heart failure. So I feel like a lot of times when you first diagnose AFib, take x-rays because they very well may be in heart failure as well. Again, more hemodynamic rather than electrical stability, unless there's something weird like a pathway. And the goal is to slow the heart rate back into that physiologic range to optimize cardiac output. There have been studies looking at electrocardioversion or defibrillation of the atria. In dogs, sometimes it goes back, but usually within minutes to days, they go right back into AFib. So we usually don't, but maybe that'll be something we're doing more in the future as we find other drugs to help prevent AFib from coming back. But usually we just do rate management. Similarly, AFib, but at a normal rate at 150. So this is either an animal that's being treated, or it could be a giant breed dog. And sometimes their atria are so big that they develop AFib with a structurally normal heart, but it doesn't cause clinical signs and their heart rates are normal. So that's what we call lone AFib. And usually we don't need to treat those, but we do like to monitor them because sometimes they can go on to develop DCM. Atrial flutter is I treat it essentially the same as AFib. Instead of chaotic activity, there's a loop in the atria that's going really, really fast, which is causing that sawtooth baseline. But I treat and manage the same way, and a lot of atrial flutters will eventually progress and become AFib at some point. Ventricular arrhythmias, we'll talk a bit about those. I'd say probably the most common arrhythmias that we see. Back in the 70s, they looked in humans about trying to grade severity from anywhere from an occasional single VPC to RMT VTAC. And in certain situations, they found that the more severe arrhythmias, the worse outcomes. We don't have any studies in dogs and cats to prove that's the case, but it seems to make sense. If you have a dog in RMT VTAC, it's probably more likely to have sudden death compared to a dog with a single VPC. But the question is, where do we go with that, or where do we make the cutoff? Like, when do we start to worry? When do we start to treat? Again, I think coming back to heart rate, and I think that really helps dictate the hemodynamic and electrical stability. You know, here's a ventricular rhythm at a normal heart rate. The dog probably blood pressure normal, probably not having clinical signs. It's what we call an accelerated idioventricular rhythm, or AER. We usually don't need to treat those. They usually don't respond well to treatment anyway. And they're almost always due to non-heart issues. So when we see those, it's always good to look at the heart, but a lot of times we find it's stuff in the belly or stuff going on elsewhere. Again, if it's regular, the dog's blood pressure is normal, and it's not having arrhythmia signs, probably doesn't need to be treated. And when it starts to getting, okay, well, the heart rate's like 160, it's 180, it's 190, now it's starting to get into the range. It's, well, is this a VTAC? Is this something we should treat? So this top strip, you know, we kind of have a pause, we have a sinus beat, and we kind of have a slow ventricular rhythm. And it's like one come in. When I see that, especially in a hospitalized patient like post-op GDV, I'm starting to lean towards saying we should at least maybe manage it in hospital. You know, maybe I would start this dog on lidocaine. Maybe, you know, ideally we get an echo, say, does he have any heart weakening or underlying heart disease? And if he does not, especially if he had a GDV, hopefully he doesn't, that'd make me maybe feel better about starting sotalol. A lot of times arrhythmias with GDVs can worsen like for the first like 3 to 5 days after a surgery. And there can be sudden death in that time frame. So I'm not concerned about this part, but when we start getting fast couplets, I start getting a little more concerned. So here's some telemetry tracings from a dog I once had hospitalized. You have a sinus rhythm, and then we have this ventricular rhythm that's at about 140, 150. I was like, okay, that's fine. But then every now and then we'd have this fast R on T couplet. And again, R on T means that the R wave of the next complex is happening before the T wave of the previous complex is done. And the reason why I start getting worried about these, again, probably not causing problems for the dog. He just felt his heart do a little double skip of the beat. But it sets up the possibility that if you have a wave of repolarization being chased by a wave of depolarization, you could get a loop where they chase each other and you potentially develop a more severe arrhythmia. And if you look here, this isn't noise, this is a little run of R on T VTAC. And you see after that, we kind of go back into this little bit slower VTAC, but still fast VTAC rhythm. But here we're noticing the complexes starting to change. And if you look closely, here the complexes are, go a little more. Here the complexes are, you have a positive QRS and a negative T wave. And then over here, you have a negative QRS and a positive T wave. If you kind of step back and look, you see it switching back and forth. So the French phrase is turning on a point, or torsades de pointe, where basically you have this electrical loop going around the heart, and it's kind of spinning around the heart. And this did eventually lead to ventricular fibrillation. So this is the concern when we start to see these couplets, triplets. It may not be hemodynamically unstable, but we're worried that it's going to become electrically unstable. So in hospital, lidocaine is really the go-to. It's cheap, it's usually effective. Side effects to watch for usually starts with nausea and vomiting. When you're giving it, stop once a dog vomits, because the next phase is going to be twitchiness or arrhythmias. Usually I don't see that until over 6 to 8 mg per kg. I did have a dog a year or two ago that had a seizure at 4 mg per kg when we were trying to break his arrhythmia, but usually it's like 6 to 8 or higher. And then I just have some CRI rates in there. In cats, really try not to give lidocaine unless it's an emergency and you have to. I usually start, like, they're way sensitive to lidocaine, and I usually do like 1/10 of the dose, like 1/4 mg per kg. And even then I've had a cat get twitchy and on that. Procainamide is another good second-line antiarrhythmic, but again, it's a little more expensive, and I think it's probably not standard on the shelf in most clinics, but I have doses on there in case you want. Magnesium sulfate can help. Can help stabilize membranes, can help with treatment of ventricular arrhythmias. The dosing is really confusing. Sometimes it's off milliequivalents, sometimes it's off milligrams of magnesium, and sometimes it's off milligrams of magnesium sulfate. So you just have to be sure you know what you're dosing and what you're calculating, and I have a bunch of numbers there kind of going through that. But it's relatively safe. I give it slow, kind of like calcium gluconate. So like I'd give like a slow bolus over 10 to 20 minutes, and then you can run a CRI. This is kind of like my second or third line of something I add in if I'm not getting good control with other things. Briefly, amiodarone, the injectable version, used to just kill animals. They had a reaction to the polysorbate 80. There's a newer aqueous one called Nexterone. Again, probably not going to have it in your clinic, but just know that is something that we sometimes may have as a third line antiarrhythmic option. Precordial thump, really not recommended. It can cause bruising of the heart and worsen arrhythmias. If they're in VTAC and if you do a good job and you actually cause a depolarization, like the hit may do up to like 5 joules of energy. If you do it on a T wave, you may cause torsades and VFib. I mean, if this animal's fibrillating and you don't have a defibrillator there, sure, because they're probably just about dead anyway. But in general, we don't recommend precordial thumps. So go home treatments. I'm gonna try to get through this in just a few more minutes. I know we're getting close on time. Sotalol is usually our first choice. It's cheap, it's effective, it's twice a day. It can be pro-arrhythmic, but usually it's very effective. It's primarily a potassium channel blocker, but like I said before, has some beta blocking properties. So I really don't like to start it without an echo. Now, I know echo availability is a problem right now. So, you know, if we're in a position where, well, should we not? I think chest x-rays can be helpful. If the cardiac silhouette is normal, they probably don't have severe heart disease, and you're probably not going to cause congestive heart failure by starting it. But they could have occult DCM. So DCM starts out by heart weakening, which then you get secondary dilation. So if we start sotalol and then we echo later and we see a weak heart, you know, it's going to be may make diagnosis a little more tricky, but sometimes that's an academic issue rather than the patient's still alive issue. So I usually try to avoid it without an echo, but if cardiac silhouette's small, and if it's a boxer that came in for collapse and you're seeing single VPCs in the hospital or even runs a VTAC, I probably still would start it. But I think that's just a conversation you have to have with the client, because I have started sotalol in some dogs and caused hypotension collapse or congestive heart failure. So it is a risk with that drug. The safer drug is mexiletine. It does not cause heart weakening. It's usually pretty effective, but the downsides are it can cause nausea, vomiting. It's every 8 hours and it's a little bit more expensive. Anecdotally, I've had some good, I think Dr. Rose kind of started with this and let me know, had pretty good success starting famotidine or Pepsid with settling the stomach, but sometimes we have to dose reduce. It's a pain in the butt. It works well with sotalol, but then you're giving a BID and a TID drug, and it can be a lot for owners. But it's safer. So it's part of the conversation I have. Amiodarone, kind of third-line drug, usually very effective, but takes a long time to build up in the system and has side effects with the liver, thyroid, and potentially bone marrow, so it requires a lot of monitoring. Fish oils, there's one study in boxers with ARVC where they saw the number of arrhythmias went down significantly. So it's one of those things that may help, may not, but probably not going to hurt. But I wouldn't use it as a sole antiarrhythmic, but something that you could add in. And again, I avoid beta blockers just because of the potential weakening of the heart. VFib, there's a bunch of information about defibrillation in the hospital, monophasic versus biphasic. This is a biphasic defibrillator. This is a monophasic one. I think if you have one in the hospital, it'd be good to review recover guidelines, when to use it, what to do after you shock. You resume chest compressions right away. And then last things that we'll just briefly look at, and again, this is probably more just for reference, is conduction abnormalities that you can find on the EKG, but don't actually interrupt the rhythm or cause arrhythmias. And they're not very sensitive or specific either. So they're things that I think can help you think about different things, but I wouldn't diagnose a dog with right atrial enlargement just based on a tall P wave. So like that's classic for right atrial enlargement, or a wide P wave is classic for left atrial enlargement. Similarly, left ventricular enlargement, you get a really tall R wave, where with right ventricular enlargement, you get a negative, very negative QRS complex. If you have a puppy with a loud murmur and you do an EKG and you see this, you may at first be like, oh, this is VTAC, but they're like, oh, well, they're not that wide, they're negative, and there's actually a P wave in front of each one. So this is like a right axis deviation. So if I saw this in a puppy with a loud murmur, I'd be like, maybe this puppy has pulmonic stenosis. So like I wouldn't use it to definitively diagnose, but that's what I start to think. Similarly, this is like what we just saw, but they're more wide, but still a P wave in front of every single one. So this is a right bundle branch block. Again, first glance, especially if they have a sinus tac, it'll look like VTAC, but if you go through your questions and you be like, actually there's a P wave with QRS for every one, that then tells you this is actually a sinus rhythm with a bundle branch block. And then this is what a left bundle branch block looks like, tall and wide. First degree AV block is just a long PR interval. Unless you're measuring it, probably not even going to notice it. So when do you treat, when don't you? Typically, I don't treat if they're asymptomatic with just single APCs or VPCs. I usually don't treat accelerated ventricular rhythms that are very stable and regular, and I usually don't treat mild second degree AV block. If they're having some faster couplets or triplets that are early from the top or bottom chambers, or if you have an old boxer who collapsed with upright VPCs, to me, I'd be like, that dog probably had VTAC. I probably would consider treating. But if you see sustained SVT, VTAC, AFib with a fast heart rate, or significant slow arrhythmias, then I would treat those. This is kind of review, like what do you do? So you're doing a pre-anesthetic exam on an asymptomatic animal. We see some single VPCs. Well, ideally we would do a full workup. We do an echo, do full lab work, you could even go abdominal ultrasound. I think part of it is, what do we see on lab work? Does that direct us towards ultrasound, or we do x-rays, do we see a huge cardiac silhouette? Is that going to direct us more towards echo? Is it an old golden? You know, I think, again, either echo or belly. Is it a Doberman? That's probably going to direct me more towards echo. So I think keeping clinical picture, doing everything is ideal. But again, if we're 6 months out to get an echo and you have a dog in VTAC, you know, it becomes a question, do you treat, do you wait, do you not? And a lot of times we don't have great answers for that. But these are all the things I'm thinking about and trying to take into consideration. And then this is just kind of a summary of what we talked about. So when do you treat, and what are the typical drugs that we use to treat different situations? So hopefully this talk will be a little bit of a good reference for you too. I know it's fast and rush. I tried to go over every EKG during the talk. I know we went a little long. I'm going to switch over and just take a look at some questions here. Right. So during a routine puppy exam of a happy, wiggly, non-clinical pup, an irregular arrhythmia was noted. Heart rate was normal. Current plan is to resculpt before an upcoming neuter. If an arrhythmia is still present, what is your recommendation for proceeding surgery? Do we do a full workup, lab work, hold off, echo? So I think the first thing would be, I would get an EKG. Because you hear something abnormal, let's just first see what it is. Does it look like a sinus arrhythmia with puppy gets excited and becomes a sinus tach and then it slows again? Do we see AV block? Do we see VPCs? So if you hear something, I would say start with an EKG so you can at least see what's going on. And then I think kind of going through this talk, hopefully I answered some of those questions as we went through. You know, how far do you go? If you see some mild secondary AV block, I'd probably do atropine before. And you could do it as like an official atropine response test. Or, you know, kind of the poor man's atropine response test is give atropine with pre-meds and make sure they have a regular sinus tach before induction. But if they don't, then be prepared to not do the procedure if they're not responding normally. If they're having VPCs, you know, maybe we do hold off and say, well, let's see if we can get an echo, or at least get some chest radiographs and say, do we see cardiac enlargement? So hopefully some of the stuff in this talk helps answer that. And the definitive answer is it's not straightforward. You know, you could do thousands of dollars of tests because you saw one VPC and you may find nothing. Or you may find this dog has liver issues or something. Is a respiratory sinus arrhythmia in a cat, especially relaxed, friendly cat, or a cat on gabapentin even considered normal, or is it something that always warrants? Yeah, good question. I think taking the attitude of the cat, is it relaxed, calm, sleeping, purring? Is it on GABA? GABA in cats I find frequently does cause lower heart rates. Usually not like, they don't come in like bradycardic at 60, but you know, their heart rate may be 120 even when they're stressed in the hospital. I feel like they're usually still pretty regular. But those are things I'll be thinking about. Like if it's a really calm cat or a cat with GI disease, maybe it does have higher vagal tone from that. So I think I wouldn't say this cat definitely has sinus node disease when I see a sinus arrhythmia in a cat, but I'm going to be thinking about, do they have other causes of high vagal tone or drugs potentially affecting it. I think that is all I see for questions right now. Anything else, Heidi, that I'm missing? Or?
Nope, I think that is it. Awesome. Thank you so much, Dr. George.